Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode reviews the article titled IT Service Management as an Operational Governance Framework for Healthcare Systems, a policy analysis of procurement and service delivery. Now let us jump right into it. Imagine a state-of-the-art hospital facility, right? You have world-class surgeons, brilliant nursing staff, and millions of dollars in advanced medical technology.
Right, the absolute cutting edge of clinical care.
Exactly. So a patient is prepped for a critical, time-sensitive procedure, and yet the entire process just grinds to a halt. And it is not because of a medical complication, but because a specific sterile supply just cannot be located in the storage ward. The clinical expertise is flawless, but the background logistics have failed. So today's deep dive explores exactly why this happens, and more importantly, how a framework borrowed from the tech sector might offer a solution. It is great to have you here to analyze this research with us.
It is a pleasure to be here. And you know, that scenario you just described is incredibly common. It highlights a fundamental truth about modern medicine. We spend so much time marveling at clinical breakthroughs, but we often overlook the operational architecture.
Yeah, that hidden wiring that actually makes patient care possible.
Exactly. The background systems are just as critical as the frontline care, but they rarely get the same level of rigorous attention.
So let us unpack the central thesis of this paper, authored by Ottari Machaladze. For you listening, whether you're involved in health policy or hospital administration, you likely recognize this persistent friction. There's this massive gap between high-level health system objectives like equitable access and rapid care and the actual day-to-day execution.
Right, the execution gap.
Yeah. So the central question this article attempts to answer is, how do we bridge that execution gap?
Well, to bridge it, the author proposes a fascinating cross-sectoral solution. They advocate for adopting IT service management, which is often abbreviated as ITSM.
Okay, so bringing an IT concept into a medical setting.
Precisely. More specifically, it relies on a well-established tech methodology called the ITIL framework, but the author is applying it in a completely non-traditional context.
Meaning not just using it to manage the hospital's computers or Wi-Fi network.
Right, exactly. The proposal is to use ITSM as a comprehensive operational governance approach for the entire healthcare system, focusing heavily on procurement and routine service delivery.
Okay, before we get into how a tech framework applies to medical supplies, I really want to establish the conceptual background. Why look outside of traditional healthcare models in the first place?
That is a great question. And to understand that, we really need to look at the current operational environment. The statistics presented early in this paper are, frankly, quite alarming.
Yeah, they really are.
The study synthesizes global evidence showing that up to 20 to 40% of total health expenditure is lost directly due to inefficiencies.
Wait, 20 to 40%. Let us sit with that number for a second. That means for every $10 million a hospital receives, up to $4 million essentially vanishes into the void of bad paperwork, lost inventory, and operational friction.
It is staggering. I mean, we are talking about deeply fragmented administrative workflows, poor procurement practices, and just fundamentally weak coordination.
In the corporate world, a 40% efficiency loss is a bankruptcy. But in healthcare, that directly impacts human lives.
Absolutely.
Okay.
And the paper goes further, highlighting that in many low and middle-income countries, 30 to 50% of healthcare facilities suffer from stockouts of essential medicines.
Meaning the vital medications needed to treat patients are quite literally missing from the shelves.
Yes, the front lines are fully staffed, but they do not have the tools to do their jobs.
You know, this brings to mind an analogy that might help visualize the current state of health policy for our listeners. If we compare a national healthcare system to a highly complex, state-of-the-art vehicle, it seems our current policy frameworks focus almost entirely on two things.
Securing the financing and training the driver.
Exactly. Securing the money to buy the car and training a highly skilled driver, which is our medical workforce. But in doing so, we are entirely ignoring the internal engine mechanics and the fuel lines. We have a great car and a great driver, but the engine seizes because no one designed a reliable way to deliver the oil.
That captures the dynamic perfectly, and that is exactly what the author identifies as a critical policy gap.
A policy gap because the existing rules do not cover the mechanics.
Right. Despite massive global investments in financing and building workforce capacity, our current health system frameworks offer almost no rigorous methodology for those internal mechanics. There is very little guidance on how internal operational workflows should actually be structured or governed on a day-to-day basis.
So, if the problem is this massive efficiency leak and a lack of internal governance, how do we plug it? This naturally moves our discussion to the core findings of the paper. How does IT service management function as the missing link?
Well, the core analytical argument is that ITSM serves as a governance translation layer.
A governance translation layer. Break that down for us.
Sure, it is a structured system that takes clinical demand on one side and translates it through administrative workflows to produce a reliable service.
Okay, so it connects the need to the delivery.
Exactly. In the IT world, ITEL, which stands for Information Technology Infrastructure Library, is essentially the ultimate playbook for how to handle services. It organizes chaotic, undocumented requests into standardized, measurable processes.
And the paper argues we can map that playbook directly onto hospital logistics.
Yes, mapping those exact IT service principles to healthcare supply chains and operations.
Wait, hold on. I have to push back here because this raises an important analytical question. A hospital ward is absolute chaos compared to a corporate IT help desk.
It definitely is a different environment.
Right, and the stakes are infinitely higher. So aren't we risking oversimplifying the profound complexities of patient care by treating hospital operations like an IT department? Are we reducing nuanced medical needs to just another support ticket?
That is a highly relevant concern, but the framework in the paper is very careful to draw a distinct line between clinical decision-making and operational logistics.
So it is not trying to dictate how doctors treat patients.
Absolutely not. The proposal is not about interfering with clinical care at all. A physician's diagnosis and treatment plan remain a complex, independent medical process.
Okay, that makes sense.
However, the operational logistics supporting that physician do not need to be bespoke or complex. They need to be standardized.
Let us ground this for the listener. Walk us through a tangible example. What does this actually look like in practice compared to how things are done now?
Let us take the example of a clinical ward needing a critical piece of equipment, like a specialized ventilator. In a traditional fragmented system, a nurse might have to make 3 different phone calls, send an email to logistics, and perhaps physically walk down to a supply room.
It is entirely ad hoc.
Right. It relies on personal relationships, and if the email is missed, the equipment does not arrive. There is no central tracking whatsoever.
Which creates incredible stress for the clinical staff, pulling them away from the patient.
Precisely. Now, if we apply the ITSM framework, specifically a concept called incident and service request management, the process changes entirely. The nurse logs a standardized request into a centralized system. That request immediately triggers a predefined workflow. And more importantly, it triggers an SLA, a service level agreement.
Oh, right. Like when an IT provider guarantees your servers will have 99.9% uptime, or that a critical network outage will be addressed in under 15 minutes.
Exactly like that. In the hospital context, an SLA guarantees that a critical operational request, like delivering the ventilator, must be fulfilled within the specific measurable time frame.
And what happens if they miss that time frame?
If that time frame is breached, the system automatically escalates the issue to higher management. It creates absolute accountability and removes the administrative burden from the clinical staff.
That is fascinating.
Furthermore, if a vital medication stocks out, it is not treated as a passive administrative delay. Under this framework, it is classified as a critical system incident.
Meaning it sets off alarms.
Exactly. It triggers an immediate high-priority resolution pathway, just like a massive server crash would in a tech company.
That is a profound paradigm shift. It takes operational failures, which are often viewed as just unfortunate, inevitable realities of running a hospital, and treats them as measurable, manageable defects.
It completely reframes how we look at logistics, yes.
But as compelling as this sounds, we need to examine the structural and methodological considerations of the study. How did the author arrive at these conclusions? Was this framework actually implemented and tested in a live hospital environment?
That is a critical distinction to make. As the title indicates, this is a policy analysis and a conceptual framework. The author did not conduct a new observational field study or a clinical trial.
Okay, so it's built on existing literature.
Yes. The methodology relied on synthesizing cross-sectoral evidence. The author reviewed diverse bodies of literature, integrating service management theory, established health systems research, and specialized procurement data.
Taking the best from different fields to build a new model.
Right. By overlaying these disciplines, they mapped established idle practices onto known healthcare operational bottlenecks.
So we have to be rigorous in acknowledging the parameters of this research. This is a theoretical mapping.
It is. And it is important to impartially report that this is, well, an explicitly stated methodological limitation within the text itself.
The author is upfront about it.
Absolutely. The framework remains conceptual at this stage. While the theoretical mapping is logically sound and the cross-sectoral evidence supporting ITSM in other industries is robust, the paper clearly states that this model requires empirical validation.
Meaning it needs to be tested in the real world.
Yes, it needs to be implemented in real-world healthcare environments and subjected to rigorous evaluation to measure its practical efficacy.
Even as a conceptual model, though, the implications are significant. Let us look at the institutional and policy implications. What happens if this framework is successfully validated and adopted?
The impact could be transformative.
For a listener who works in health policy or perhaps manages a regional health authority, what are the tangible institutional benefits of implementing this kind of structured service architecture?
Well, the potential benefits are incredibly high. The study cites evidence from other complex service environments where similar frameworks have been adopted, showing that structured approaches can reduce operational delays by 20 to 30%.
Wow, a 30% reduction.
Mhm.
If you translate a 30% reduction in operational delays to a busy hospital, you are talking about significantly faster patient care, optimized use of staff time, and a massive reduction in financial waste.
Exactly. And it also fundamentally changes the visibility of the supply chain. You mentioned accountability earlier with the service level agreements. This framework essentially introduces a layer of total transparency into the system.
Because everything is tracked in a central system now.
Right. By moving away from undocumented phone calls and hallway conversations toward structured digital service requests, every single operational action becomes trackable.
So no more guessing where the supplies are.
No. An administrator can look at a dashboard and know exactly when a supply was requested, who approved it, where it is in transit, and how long it took to arrive.
Which takes us back to those stark statistics we discussed earlier, the 30 to 50% stockout rates in certain regions.
Yes, and the author emphasizes that this level of transparency is of paramount importance for resource-constrained settings.
Because when funding is severely limited, you simply cannot afford inefficiencies.
Precisely. Improving the reliability of service delivery in those environments is not merely an administrative goal, it is an absolute public health necessity. You have to ensure that the limited resources you do have actually reach the patient.
This naturally leads us to a broader system-level reflection. We are moving beyond just saving money or speeding up a single hospital's supply chain. It seems the broader implication of this paper is a necessary paradigm shift in how we view health systems entirely.
It really is a macro-level shift.
Yeah, I mean, operational inefficiencies like a delayed procurement order or fragmented communication between the pharmacy and the surgical ward, these are not just annoying administrative hurdles. They are major, severely underaddressed determinants of overall health system performance.
That is the exact macro-level reflection the author invites us to make. If we connect this operational methodology to the bigger picture, ITSM emerges as a foundational tool for building overarching health system resilience.
Resilience being the key word there, especially lately.
Exactly. We have seen global health systems face unprecedented systemic stresses over the past few years. This paper suggests a crucial insight, which is that systemic resilience does not solely come from injecting more financial resources or simply hiring more staff.
Right, because if the foundation is chaotic, adding more weight to it only makes it collapse faster.
That is exactly the point. True resilience comes from having a reliable, underlying operational architecture. By shifting to a service-oriented model, an institution transforms its entire operational culture.
It stops being reactive and becomes proactive.
Yes, it moves away from ad hoc problem solving, where brilliant clinical staff are forced to constantly invent workarounds for broken administrative processes, into a coordinated, predictable architecture.
And when a system is predictable, it can absorb shocks.
Precisely. It can adapt to sudden surges in patient demand or sudden supply chain disruptions because the mechanisms for routing resources are already standardized and battle-tested.
To conclude our deep dive today, let us synthesize the journey this analysis has taken us on. The paper began by identifying a massive, costly structural flaw in global health systems, up to a 40% efficiency loss and severe supply chain failure.
Right, a massive operational crisis.
And it diagnosed the root cause not as a lack of medical knowledge, but as a critical gap in operational governance. We have over-focused on the what of healthcare while neglecting the rigorous management of the how.
And in response to that gap, it presented the conceptual proposal of adopting IT service management. specifically utilizing the ITOL framework to serve as that missing governance translation layer.
Standardizing logistics so clinicians can focus entirely on care. We highly encourage you to review the full text of this article. Examining the detailed mapping of these IT principles to specific clinical and administrative workflows provides a much deeper understanding of how we might bring the exact same rigorous standardization to our internal operations as we already do to our clinical practices.
The operational engine of healthcare requires and deserves our focused analytical attention.
Absolutely.
I agree entirely. And as we consider the integration of these cross-sectoral frameworks, I would offer this final thought for you to consider. If healthcare workflows eventually do achieve the measurable digital standardization of the IT services sector, we generate a massive amount of operational data.
Oh, that is a really interesting point.
Right. One must wonder how that resulting predictive data might allow institutions to utilize artificial intelligence to anticipate and resolve operational incidents, like a localized stockout, hours or days before they ever actually impact patient care.
Thank you for listening to the GMJ podcast. For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description. We look forward to continuing these scholarly discussions in future episodes.